All right. Well, hello there. My name is Jesse Casaubon. I'm one of the breast cancer surgeons working here at the Baystate Breast and Wellness Center. And today I'm here to talk about why timing matters for mammograms. I have no financial disclosures. I just want to start by saying that we've got a great surgical team here. It's not just me. We have two other surgeons, and we have a new breast surgery fellow who is training to be like us. We've also got nurse practitioners, nurse navigators, and many other excellent staff members who help us take care of our patients who have been diagnosed with breast cancer. But there's a lot more people needed to treat breast cancer than just us here in the surgery group. We work with a number of different teams at Baystate, including the medical and radiation oncologists who are over at the Damore Cancer Center. We also work with pathologists, plastic surgeons, physical therapists, and one really important group of people. The ability to detect and then precisely target breast cancer for removal is really dependent on the radiologists. And the radiology department is where most women begin their evaluation, whether it's going in for their screening mammogram or when a new problem arises, going over there to have it looked at. So before even the radiology team, though, treating breast cancer begins with you. This is a picture, one of the Rays of Hope walks a couple Octobers ago. This last weekend was the Rays of Hope fundraiser charity event walk that was virtual. Anyway, our ability to successfully treat breast cancer starts with you, the women in the community who go for their mammograms every year. And not just you, but also your friends and family and the people who support and encourage you. Again, this is Breast Cancer Awareness Month, so there's no doubt that you're seeing a lot of ribbons, hearing the stories of survivors, seeing things on the news. But one of the main components of the awareness in Breast Cancer Awareness Month is recognizing the benefits of mammograms and then getting them done. And I know many of the reasons why screening mammograms are difficult, and I don't want to minimize the downsides because I know. But I want to talk about the upsides of mammograms, how they can save your life and why the timing matters. But first, we have to review a couple things. We need to talk about what a screening test is and then how the screening mammogram works. We next need a quick review of how breast cancer develops to understand how mammogram plays into all of that and how it detects it early. So you've probably all heard of a test being done for screening purposes, but what does that actually mean? Screening tests come in a lot of different varieties. They can be blood tests, they can be x-rays, they can be CAT scans or mammograms. They can also be procedures such as a colonoscopy. The one thing they all have in common, though, their one goal is to detect a disease before you have any signs or symptoms of it, which is to say, to find it early. So with breast cancer, the goal is to find it before it's big enough to feel on exam. But this only helps us if finding it early means that we're better able to treat it. And lastly, these screening tests must be tolerable enough to where people will actually volunteer to have them. So let's look at mammograms and breast cancer and see if this is all true. So what's a mammogram? A mammogram is a low-dose X-ray of the breast, which allows us to see breast cancer in its earliest form. The breast is looked at in two angles. So this is how we see a normal mammogram when it's done. So this is with the breast compressed vertically, looking from the side in. So all the way to the left, you have a picture of the right breast, and then next is the left breast. And then the two images on the right, this is looking at the breast from above, like if you're looking right down on it with it compressed horizontally. And so this is exactly what we see, the two views of each breast. And here's what an abnormal mammogram looks like. This is a picture where you can see that in the right breast, there is a mass developing. And this, this kind of looks like an obvious mammogram because this is a mass that's on the larger side, but breast cancer typically starts a lot smaller than this. It starts with one abnormal cell that slowly begins to multiply. So this is the anatomy of the breast, with the two main components being these glands here. I hope you can see my pointer, these glands that make milk, and then these tubes that transport milk to the nipple. If we were to blow up a picture of those milk glands and milk tubes or milk ducts, it would look something like this. You've got the milk-making glands and those tubes that go down to the nipple. So most breast cancers start right here in one of these tiny milk ducts. These ducts are made up of little cells. This would be like if you looked at the cross-section of it, you see that it's made up of all of these little cells, like the same cells that make up everything in the body. But for whatever reason, every once in a while, one of those cells can become abnormal, and it can start making copies of itself. It can start to multiply. When it develops the ability to keep multiplying and to spread, that's what we call cancer. And the first thing that happens is those cells that are multiplying, they build up inside of the milk duct. And the more of those cancer cells that build up in the milk duct, the more they show up on mammograms. So mammograms help us spot the earliest form of breast cancer, which is when you just have abnormal cells or cancer cells that are still stuck inside of these tiny microscopic milk ducts. So this is something you may have heard of. We call this a stage 0 cancer, when the cancer cells are still stuck in that milk duct, or something called ductal carcinoma in situ, or DCIS. So here's a picture of what DCIS might look like on a mammogram. This is one of these mammograms, but just zoomed right in on a tiny little spot, because this is often so tiny you can barely see it. But these are probably two milk ducts sitting next to each other that have a buildup of these cancer cells in them. So what happens with time is enough of these cancer cells build up in that milk duct and eventually are able to break free from it. There's so many that they can't fit in there anymore, and they break out of there and they form a mass in the breast. Well, mammograms also work for this too. They detect these cancerous masses even when they're extremely small, like measured in millimeters, like something the size of a pea. And this is important because we typically don't feel either of these things. We don't feel the cancer cells in the microscopic milk ducts because it's incredibly small, and we don't feel things the size of a pea. It's just a little bit too small. So mammograms let us detect breast cancer before we can feel it, which is to say early. And so we were talking about screening studies, and we said, well, that really only matters if we can do something about it when we catch it early. And that is exactly the case. So to think about this, you've got breast cancer that starts small in those microscopic milk ducts, and with time builds up and it breaks free and forms a mass in the breast. But the smaller that area is, the smaller that mass is, the easier it is to remove. So this is an example of one of the surgeries we might do, something called a lumpectomy, where we're able to target the small area and remove it from the breast using a small incision and save the rest of the breast. Problem is that if time continues to pass and the cancer is undiscovered, the mass will grow bigger and bigger and bigger, and as it grows bigger in the breast, it becomes more difficult to remove. With more time, months or even years, the cancer can eventually spread elsewhere. That's the thing that we're worried about with any cancer. And the first place that breast cancer typically spreads to is the lymph nodes under the armpit. Once it has spread to the lymph nodes, we often have to talk about chemotherapy or additional surgery, something called an axillary lymph node dissection, where we have to surgically remove all of those lymph nodes from the armpit. The problem is, chemotherapy is difficult to get through, and when we take all of the lymph nodes from under the armpit, people are at risk for this permanent swelling of the arm called lymphedema. So you may still be saying, well, how does this save lives? It's simple. It's all comes down to this thing called stage. Stage is like how far has cancer spread, and that's how I remember it, because stage is an S and spread is an S. And so when cancer is still stuck inside those milk ducts, it's something we call a stage 0. When it breaks out of the milk ducts into the breast, or spreads into the breast, it's a stage 1. And then as it continues to grow and spread to the lymph nodes, whether it be a large mass in the breast or cancer in the lymph nodes, that's stage 2 and 3. And stage 4 is when it spreads somewhere else in the body. And so people do better when you catch it at an earlier stage. So it's much easier to treat and to cure a stage 0 or a stage 1 cancer than it is to treat and cure a stage 2, 3, and 4 cancer. So that's how mammograms work. They catch it when it's stage 0 and stage 1, and we can do something about it. So just to review, mammograms work by catching it early when it's tiny, when we can use a smaller surgery to treat it. We can often save the breast if someone prefers that. It's less likely for us to need to remove all of the lymph nodes. It's less likely for us to need chemotherapy. And despite not needing more aggressive surgery and chemotherapy, people still do better. So I think that's all really exciting. There are a couple of downsides, and we always get a lot of questions about these. Should I have the mammogram? I'm worried about radiation. And that's true. There is radiation associated with mammograms, but it's a very low dose of radiation. It's probably similar to the amount of cosmic radiation you get just in a flight from Boston to LA. It's the same amount of radiation you get just by living on the Earth's surface for a month. So living for a month is about the same amount of radiation as having a mammogram every year. It's just a little bit more, or around the same as an X-ray of the chest. So it's essentially like doing a chest X-ray once a year. And so this is this chart's just a little example of this and what the dose is. If you were to compare it to something like a CAT scan of the abdomen and pelvis or of the chest, it's much, 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 much lower. And so people always ask, though, well, it is radiation, and doesn't radiation cause cancer? And the answer is yes. But because the dose of radiation is so low with mammograms, the chance of it causing breast cancer is maybe 1 or 2 in every 100,000 people. But I think it's important to compare this just to the chance of getting breast cancer for the average woman. So the risk for getting breast cancer is scary. It's 1 in 8. 1 out of every 8 women in America will get breast cancer. And so this just shows that it's the most common cancer of women. And this was 2018. There were 260,000 women diagnosed in America with breast cancer. So that's scary. So what we want is, if someone's the unlucky person who's going to get it, who's going to be one of those 1 in 8, we want to catch it early, and that's why we do mammograms. And so you might be saying, okay, that sounds good, but is there evidence to prove this? And there is. The reason we know that mammograms save lives is because there have been a number of large studies. This really started in 1963, was the first study, kind of when mammogram was just becoming a thing. And what these studies did was they compared 2 groups of women. They took one group of women and did nothing besides the usual exam with the OBGYN or the primary care doc. And in the other group, they added on yearly mammograms. And what they found was that the group that was having the mammograms every year was living longer, significantly longer. And so that was surprising. And that's one of the reasons why all of, every recommendation out there is now to go and get a mammogram. So multiple studies, though, not just that one starting in 1963. For women who are 50 and older, they found that mammograms led to a 30% increase in how long you are going to survive. And so that's exciting. But what happens is, or what we see is that women who are between the ages of 40 and 50, it's a little bit less clear. And that's kind of the purpose of the talk, and where we see some controversy. And so there are a couple of things to think about with this group of women who are 40 to 50. We know that mammogram is like an X-ray. And we know that the breast is made up of these milk-making glands and those little tubes that'll transport that milk. Here's the problem. The younger that somebody is, the more active those milk-making glands are, and the more active they are, the more dense the breast is, and it's harder to see through a dense breast with an X-ray, and an X-ray works by seeing through something. So because of this, because the breasts are more dense, mammograms don't work as well for women who are 40 to 50. And the other thing is that women who are younger have less risk for breast cancer. It's a disease that's associated with age. So the risk for somebody who's 40 is 1 in 69 of getting breast cancer compared to the lifetime risk of 1 in 8. So you're less likely to get it, and the breasts are more dense, so the mammogram's a little bit less useful. And so because of that, basically, I just wanted to put in a picture. This is what a mammogram looks like of somebody with very dense breasts. So you can see that almost everything's white, and it would be a lot more difficult to see those little spots of early cancer cells in the milk duct or see any sort of mass. And again, because of this, pretty much every society has a different recommendation for what age to start mammograms at. We basically all agree that at age 50, you should start doing mammograms. There's not really a lot of controversy around that. The risk goes up from 1 in 69 at age 40 to 1 in 40 at age 50, and the breasts are not so dense, so now we can get a better picture. So again, at age 50, we all agree you should start getting mammograms. It's a little bit less clear for the 40 to 50 group. We see a lot of studies that still show an improvement in survival. So women who are age 40 to 50 who are getting yearly mammograms still seem to do better, seem to live longer. But you don't see cancer as often, so you have to screen more patients. You have to perform more mammograms to detect the cancer. But then a couple of years ago, a new type of mammogram came out, something called a tomosynthesis, or what people refer to as 3D mammograms. And what 3D mammograms do is they allow us to better evaluate dense breasts. So here is kind of an example of, this is kind of a low quality series here, but the 3D mammograms take pictures at intervals throughout the breast. So they almost look from one side to the next. And what you can see in these pictures is that in someone who has more dense breasts, it breaks it up into the little segments so that you can see something that's hiding. Right here, you can see that this mass is hiding that you might not have seen on the other pictures. So most practices around the country, including Baystate, have now implemented these 3D mammogram units. And that still doesn't really answer the question of when to start mammograms. And to be honest, the answer isn't completely clear. But every single day we see young women diagnosed with breast cancer, and we see the discrepancy between people who find it late when it's larger and it's already spread to the lymph nodes, with those who find it early, who are undergoing mammograms and we're easily able to treat it. Because of that, most providers who treat breast cancer recommend starting at age 40. We see mammograms work every day, and that's why we do it. In fact, these are the formal recommendations from the American Society of Breast Surgeons. They published this in 2018. And they recommend starting at age 40 and doing mammograms every year, and even go on to get a little bit more involved by saying we should be assessing the risk for breast cancer. And if the risk for breast cancer is elevated, let's say you have like a strong family history of breast cancer, you should be doing more than just the mammogram every year. Maybe you should add in an MRI, or maybe you should think about an ultrasound or something like that. So we recognize that not every person will adopt the recommendations to start at 40, and we know that there's a lot of controversy in the community. But it's something that I do think it's worth talking to your primary care physician about, or us over here at the Breast Health Center if you want to discuss this more. Here's one more recommendation from the American Society for Breast Surgeons, just boiling it right down. even if your risk for breast cancer is average, start screening mammogram at age 40. And that's really all I've got. So I hope that was easy to understand and clear. And I think it's a difficult topic just because you saw there's so many different recommendations out there. But if you were to ask me what my recommendation would be, I would say start at age 40 and do it every year. And again, that's because I see it work every single day. So thank you.
Thank you, Dr. Casaubon. That was really great and informative. So I learned some new things this evening. If anyone has any questions, you can type your questions in the Q&A box and we'll get to them now. Okay, we have a question. Do dense breasts get less dense over time?
That is a great question. And the answer is yes. And so that's why we see mammograms work better for women who are older. Usually it happens around the time of menopause, but when the hormones change with menopause, it's those hormones that are stimulating the milk-making glands to kind of be ready in case you're going to nurse. But after menopause, we see the hormones go down a little bit. And with that, the milk-making glands, everything kind of slows down. And so it's the density goes down. We're able to see better. So yes, that's why there's really no controversy about starting at age 50. We can get a good picture with the mammogram, and that's breast cancer starts becoming more common. So yes.
Great, thank you. If you've had breast cancer and dense breasts, should you have ultrasound in addition to a mammo?
That is an excellent question. So somebody who has a history of breast cancer and also has dense breasts, we know that the mammogram's not as good. That being said, the new 3D mammograms are better. So they're a good tool, and most people in that situation will end up still just doing the 3D mammogram every year. But sometimes it's worth having a conversation with your doctor, whoever is treating the cancer, because we sometimes do more. There's something called mammographically occult breast cancer. So it's like if the breast cancer that happened to this person didn't show up well on the mammogram, we will sometimes use like an MRI in addition to mammogram. So it's like you're doing one test every 6 months. You can do that same thing with ultrasound, where you're doing a mammogram and then 6 months later an ultrasound of both breasts, and then 6 months later a mammogram. So kind of in summary, you can use an ultrasound in addition to mammogram or MRI in addition to mammogram. The ultrasound, it's a comfortable test, but it's not so good at picking up cancers. So probably mammogram's still better than ultrasound. It helps that it's something in between every 6 months, but MRI is really the best to find cancers. The problem with MRI is it's so sensitive that in the people who are having the screening with it over time, it picks up things that aren't cancer, and we end up kind of having a lot of anxiety because you'll have this MRI for screening after you've had breast cancer, and it'll show something, and we'll all get nervous, and we'll go and do a biopsy, and then it'll be nothing. Or it'll show something, and we'll go and do a biopsy, and it'll end up being some atypical cells, and we don't really know what caused them, so we typically go and do another surgery to remove those atypical cells. So it's like MRI is leading to a lot more things that we have to do, and a lot more fear. But that being said, the main upside of doing MRI is that if it is a cancer, another cancer, or that cancer coming back, it's going to find it because it's so sensitive. It picks up everything. So I think it's worth a conversation. If you are in that category, you've got the dense breasts, you've had the history of breast cancer, I do think it's worth a discussion.
Great, thank you. Tina would like to know, can you still have an MRI if you've had reconstruction and have an implant?
You can still have MRIs, but we typically don't see a big benefit of doing screening, like using MRIs every year for someone who had breast cancer, had mastectomy, and had reconstruction. So the most common way that we follow people is just by examining the skin every year and having them examine the skin with us. Because in someone who's had a mastectomy in reconstruction, if the breast cancer is going to come back, we hope it never comes back, obviously, but if it's going to come back, we usually feel it as a firm nodule in the skin. It feels like almost a BB in the skin around the incision, or it comes back somewhere else. So, but it's we don't typically use MRI for screening in someone that's already had a mastectomy. And part of the reason is because after you've had the mastectomy, the chance of it coming back is low, which is good.
Excellent. Thank you. Colleen would like to know, does being on birth control have any impact on breast density?
It probably does, actually. Those, those are the same kind of hormones that that probably stimulate the glands. But that being said, I don't think that it's one of those situations where stopping the birth control pills would cause your breasts to go from being dense to not dense. There's probably a genetic, and also just you are who you are, your body. So I don't think that stopping them would dramatically change. It might change a little bit. I think they are, associated, but I don't think it would change enough to make a big difference.
Thank you. Next question. If cancer is in the milk duct, is there a link between breastfeeding and breast cancer?
Oh, that's a good question, and I'm glad that came up. So there is a link, but it's not the link that you are thinking of. It actually works the other way around. We know that the hormones are what stimulate a lot of breast cancers to form. It's the same thing we've just been talking about with the birth control pills. Hormones cause the glands and the milk ducts to be more active, which is to say they cause them to be ready for breastfeeding. But when you actually are breastfeeding, the hormones change. And so what happens is just the act of breastfeeding actually turns down the estrogen and the progesterone in the body. It makes it less likely for you to get breast cancer. So for every year that someone breastfeeds, it's a 4% decrease in the likelihood of them getting breast cancer. So breastfeeding is actually protective, and we recommend doing it.
Great, thank you. Would there be a next question? Sorry. Would there be a case of using traditional mammograms compared to 3D mammograms? Or
Yeah,
is everyone getting 3D mammograms?
Awesome question. I love it. So that's perfect, because we do have people that are concerned about the radiation with mammograms, and the 3D mammograms do have a little bit more radiation. So if you've got somebody who has less dense breasts, the traditional mammogram is going to have less radiation and still be able to pick up anything. So that would be like a perfect scenario. You have breasts that are not dense, but you're concerned about the radiation dose. Looking at it in perspective, it's we still don't think it's the radiation that's going to cause cancer or something like that. But if that's something that you're thinking of and worried about, then that's the perfect example of when to use the traditional mammogram. Because the radiation doses are still low and they're not so different, most people just end up getting the 3D, but that would be the scenario or the time when you could say, I still want to do the 2D. There's actually still a lot of places around the country. Baystate's like we're like a tertiary care breast center, so we've got all the stuff. But if you do mammograms kind of out in some of the community centers, they've just got the old 2Ds, which still work. And the interesting thing is, we talked about all of those studies that found that women who were having screening mammograms were living longer. But all of those studies were from years ago when we didn't even have the quality of mammograms we had now. So even before the 3D mammograms, just the fact that we're able to get these digital pictures that we can blow up to be giant, the quality is so much better than the old film mammograms that they were doing in the time of those studies. So I think that just emphasizes probably we're doing so much better, but now there's not, like I said, pretty much everybody recommends screening mammograms. So we're not doing these trials anymore because we know there's a benefit of doing them. Anyway.
Oh, that's so great. I just got a chill from you saying that. That's awesome. We have another question. if I believe she means if I had breast cancer and currently has lymphedema of the breast, would that impact the mammogram results?
Probably a little bit. Fluid, we're able to see through fluid pretty well on mammograms, so I think we'd still get a good picture. But just, with lymphedema of the breast, we see things, it's probably a little bit tougher. That being said, if you've had surgery of the breast, which I'm guessing you had, that's also something that causes it to be a little bit more difficult to see. So kind of the key with all of that is you need to be, the 3D mammograms help, and also being at a big center where they treat a lot of breast cancer patients helps, because when you have radiologists who are dedicated to looking at breast images, they're able to pick up what is, treatment effect. If they see something, they're able to say, oh, that's the scar from surgery. I see that every day, and that's what it looks like. Or that's just swelling of the breast. That's lymphedema of the breast. It's not something we have to worry about.
Thank you. If next question, if I have dense breasts, is that impactful if I'm having breast surgery?
It doesn't change too much of what we're doing in the breast surgery side. Pretty much it's still the same. I mean, the surgeons can kind of notice. We know who's dense and who's not dense when we're in there working, but it doesn't really change our ability to take care of any of the problems.
Excellent.
If anything, having the more dense breasts, they have it's almost like more blood flow just because those glands are really active. So I think that people tend to heal maybe just a little bit better because you've got that good blood supply. So I think if anything, you probably do a little bit better.
Thank you. Next question, sorry. Do most breast cancers happen in the milk duct?
Yeah, about 75% of breast cancer starts in the milk duct. Occasionally it does start from somewhere else. It'll start from one of the milk-making glands, being the second most common. But yeah, most of it does come from the milk duct.
Sorry, there's one more question coming in. The last one we'll take tonight. How accurate are the mammography screenings?
That is a great question. And so it breaks down into a couple of different things because there's a couple of different things that happen. So we break this into two categories when you're doing the mammograms. You have things that are true positives. So true positive being that the mammogram shows something and we biopsy it and it's cancer. That's what we want to happen. It shows it and we find it. But we also see false positives where the mammogram shows something and we biopsy it and it's not cancer. So that's the mammogram showed us something that looked like a positive mammogram, but it didn't end up being anything. So that does occasionally happen. And that's one of the downsides of mammogram is that we sometimes run into things that we didn't need to know about. Like we do a biopsy and it's something completely benign and we don't have to think about it anymore, but you had the biopsy for it and the scare associated with all of that. And then we see true and false negatives where the mammogram looks perfectly normal and it is perfectly normal. There's nothing in there. And then the rare event where the mammogram looks perfectly normal, but there is something in there. And that's the group that we worry about with the dense breasts because we sometimes don't get the same view. But mammograms in general are very, very accurate. And so, I mean, I still think they're a good test, but it's just one of those things that it's hard to wrap your head around because it's often very scary when you get the call back and they say, we found something, we want to take another look, or we found something, we want to take a biopsy. The chance that biopsy will end up being cancer is like 25 or 30%, which is, I guess, reassuring, but also not reassuring because the most likely thing is that it won't be cancer, but you probably also don't want to go through the trouble of having more pictures or whatever. So So that's kind of the number we give, is if a mammogram shows something, it's about a 25 or 30% chance of it actually being cancer.
It's the very last one. It seems like a short amount of radiation focused on a breast could be a lot more intense than a 7-hour flight.
The chest x-ray and the risk of that chest x-ray causing a problem is essentially zero. It's a very low dose of radiation.
Oh, okay. With radiation spread out over time in a larger area.
I see a question about women who are 70 and older with dense breasts and a family history. I mean, for the question for Kathy Lyons, the women who are 70 or older with the dense breasts and the family history. Yeah, what we usually do is we can take the family history, because there's different degrees of the family history. We can plug everything into, we have like a computer algorithm that essentially calculates your risk for getting breast cancer, which is kind of scary. But if that number, your risk for getting breast cancer is more than 20%, we'll sometimes still use mammograms even for someone who's 70, or sorry, still use MRI even for someone who's 70. I think it's perfectly reasonable. It's a difficult test to get through, which is why we don't always do it. You know, we talked about screening tests being tolerable. The MRI is a test where they put in an IV, they give you a dye, you go in this noisy tube for about 45 minutes where you have to lay perfectly still. And it's not kind of like the regular CAT scan where you're laying there on your back. It's like you're on this table and they've got essentially two holes cut out for your breasts so that they can look at them with a magnet. And so it's an uncomfortable test, which is why we sometimes don't do it. But it's worth talking about, yeah.
Well, thank you very much. Great Q&A, great presentation, great information about mammography. So thank you very much, Doctor, for your time and your expertise. We really appreciate it.
You're very welcome. And again, I'll just say, if you give us a call, if anything. My last slide had our phone number, which is 794-8141. I do recognize some names out there too, so reach out to us if you need anything or you want to talk about this stuff more.
Thank you. Have a great evening.